Welcome on World Tapering Day. It's a pleasure for me to speak to you. And I will give this presentation before Jim van Os, who will talk after me. And after we have both given our presentations, there will be time for discussions and for questions. And before I begin, I want to thank Carol for all the magnificent works he has done to make World Tapering Day possible. Okay. Now, these are the tapering strips I will be talking about. And this is our mission. What we want is to make responsible and personalized tapering of psychotropic and other medications practically possible, based on shared decision-making and proper self-monitoring. I myself and Jim van Os, we are involved in the development of and in the research into the use of the tapering medication, but not in producing it or providing it to patients. We do not receive any reimbursement or income from the provision of tapering medication, but the User Research Center at UMC Utrecht has benefited from an educational grant provided by the Regenboog Pharmacy. About myself, I am not a medical doctor. I studied chemistry, biochemistry, molecular biology, and I did fundamental genetic DNA research for quite a number of years at different institutions, among which the Netherlands Cancer Institute, the veterinary faculty, and the pharmaceutical faculty at the University of Utrecht. And I got my PhD in Amsterdam at a free university. I have lived experience, that is that for a number of years I've had what you might now call severe depressions with suicidal thoughts, which have haunted me for years, which had definitely something to do with the death of my father more than 40 years ago, because he ended his own life. Anyway, in 2004, my depression was so severe that I could not work at that moment, and my temporary job ended, so I got without a job. And finally, after many years of doubt, I went to a psychiatrist and I asked the question, is it useful for me to start using antidepressants? And so I did. And once I used them, it took me quite a while to discover that even for getting a single dose would cause a very bad day the day after. And in the beginning, I did not know that this was withdrawal. Now it's clear to me. And if it happens that I forget to take a daily dose, then I experience this the next day. I'm not afraid anymore. I'm just angry that I forgot to take this pill. I take a new one and things are over, which is a big difference from being scared if you don't feel well and think you are going to be depressed again. And in 2012, I think I did an NS1 experiment in which I tapered my antidepressant hyperbolically. And this was studied this was published, this study in 2016. I don't have the time to tell about it, but it taught me a lot of things which I am also using now in our research and in the way we use the tapering strips. And in 2012, because I started studying psychology in part-time, after I got this depression in 2004, I got my bachelor in psychology. Now, problems with prescribing and tapering. You've heard a lot about them already. And one thing is clear, we don't have good guidelines. Second thing that is clear, that recommended dosages are problematic because they basically force medicine to use a sort of one-size-fits-all approach. And this is problematic. First of all, drugs are only available mostly in a few standard dosages. There are not so many exceptions, like 10, 20, 50 milligram. While what is needed, especially when we are talking about withdrawal or tapering, is that we should be able to prescribe every possible dose to make flexible tapering practically possible. But these very low dosages, which are required for gradual hyperbolic tapering, they have never been supplied by pharmaceutical companies. And often they still are not supplied. And through all these years, psychiatry has never asked for these lower doses. And then a problem with guidelines for withdrawal, insofar that they exist, and basically they don't exist. But if there are recommendations, these recommendations are based on group research and on what we call expert opinion. But for this expert opinion, there is no evidence-based. So basically, we don't know what to do with them. And if there are recommendations, they often, almost always, do not account for the heterogeneity that exists, for the large inter-individual difference that exists between patients. And to make this clear, I've made this picture. And this is, if we would know the withdrawal risk of a great number of people in a certain population, we could draw a curve something like this, where on the left side, people have low risk of suffering from withdrawal if they taper, and people on the right have a high risk. And I enlarge this picture. And typically what is tried from within medicine is to partition such population of patients in different groups so that we can prescribe the right treatment for the right patient. In this case, I have drawn 3 different groups. This group can be defined as high risk, this as average risk, and this as low risk. And then if we would have a guideline, in the guideline it would say, for this group, you should prescribe a slow taper. For this group, you would prescribe an intermediate taper. And for this group, you should prescribe a fast taper. But if you think about it, you probably immediately realize the problem here. The first thing is we don't know anything about this distribution, at least far too little to do anything useful with it. Secondly, if you go to a doctor and your doctor talks to you, listens to you, and then says, oh, you are probably in this low risk group, so you can taper very quickly. But actually, you may just as well be here and you need a slow taper. So we know far too little to do this, and it's not meaningful to make 3 different groups to partition a patient. Or in the Netherlands, there's a committee that has simply divided patients in 2 groups, one with supposedly high risk and one with supposedly low risk. And it doesn't make sense because there is a whole spectrum of how people should taper, how slow or how fast they can taper, or how slow they should taper. And for withdrawal, this leads me to the conclusion that for an individual patient, we cannot predict if and when withdrawal will occur, how severe withdrawal will be, and how long withdrawal will last. Therefore, tapering should be personalized, adaptable. It should be based on proper self-monitoring during tapering and not so much on predictions without a firm evidence-based before tapering. And it should be based on shared decision-making. And finally, we think, and we are not alone, if there is uncertainty for both the doctor and the patient, it should be the patient who decides about how to taper further. Now, many patients have understood this much better and earlier than many professionals. And the evidence for this, I think, are all these Facebook groups, well-moderated websites, where people have seriously tried to help other patients, and in doing so have come up with a lot of very useful knowledge, which is really helping patients. I don't have time to tell something about the origin of history of tapering medication in this talk. Jim will tell something more about it, but it has been described in this review. So if you want to read it, you are welcome. And I just want to make one remark, and that is that tapering medication was made at a request of patients to do what the pharmaceutical companies had not done and that psychiatry had not asked for. And in 2012, 2013, I have been searching together with the chairman of the Foundation Cinderella for a pharmacist who was able and willing to make and provide the tapering medication to patients. And that is the tapering medication we were thinking about then. And we were very lucky to find Paul Harder, who was not only willing and able to make the tapering medication, but who also had a number of brilliant ideas, who have made the tapering medication we have now available for patients. And not only for the two antidepressants we had in mind then, venlafaxine and paroxetine, because we were not thinking much further, but by now for a lot of other medications too, because it became more and more clear that also for other medications than paroxetine and venlafaxine, there are problems of withdrawal which have to be solved. Now, how tapering strips work, you can see on this slides, and I'm not going to explain this because if you take a look at it, I think you can understand how it works. This is how the strips look. The number of pills in each sacket can differ, but because we use this system, we can take care that basically every schedule you want to prescribe to a patient as a doctor is practically possible. Now, an important question in daily clinical practice, both for doctors and for patients, is how do I choose a tapering schedule? How do I know that the tapering schedule I choose will be good enough to help me taper safely? And the problem is that you yourself as a patient, you don't know what your risk is for withdrawal. Well, sometimes you do. If you have tried 5 times before to stop and it didn't go well, then you can be pretty sure that you are very sensitive to withdrawal. But if you have never done this, you cannot say that. But nevertheless, it can be that you turn out to be one of these people who is at this part of this distribution and who gets withdrawal complaints even if you don't expect it. So how do you choose it? Well, the best thing given the uncertainty you have is to choose for a schedule of which you know that many people can at least taper completely if they follow that schedule. You're not completely sure that it will, but this is possible, and it's now possible using all the data we have, all the experiences we have, everything we've heard from patients. It's possible to ask a personal advice for a patient to the pharmacist of the Regenboog pharmacy. What is a reasonable schedule to start with? And if you do that, and the answer is you can do this with 4 tapering strips, then if you are one of these patients here, then you will probably be able to taper without much problems or with no problems at all using these 4 tapering strips, and that's that for you. But it can also be possible that you are not in this group, but you are somewhere located here, and the tapering is too fast for you. Then what will happen is that you will start experiencing withdrawal symptoms, say somewhere here, and then you better not continue tapering further, because this will almost inevitably result in further worsening of your withdrawal complaints, know what you should do. So not go on taper as planned, but what you should do is stabilize. And stabilization is easy to understand why this is useful, because you are going too fast. Your body does not have enough time to adapt to the doses that is getting lower. So once you get complaints, and if you stay on the same dose, you give your body extra time to adapt to that dose. And if you have only beginning withdrawal complaints, there's a good chance that if you stabilize, that you will start feeling fine after some time. And once you feel fine and strong and well enough, you can continue tapering further. But because you know that here you were going too fast because you were having these complaints and you don't want to have these complaints again, you damn well go on further, but at a slower pace. And in this way, together with your doctor, as a patient, you can try to come neatly to the end, or perhaps discover that it's not for you to taper completely, but at least you can do it in a responsible and careful way. Now, the big question, do tapering strips help? Our answer is yes. We've done 3 studies with over 2,000 patients that show this. I'm not going to tell you about the results of these studies because they have all been published and because I don't have enough time to do that. But these 2,000 patients, we could get their cooperation because many patients have by now, at least in the Netherlands and partly in other countries, used the tapering strips to come off medication. So we can send them questionnaires afterwards and ask them, how did the tapering go for you? How much withdrawal did you have? And if you had previously tried to taper, we can ask the same question, which gives an within-person comparison of tapering with and tapering without. And that's very strong evidence for if the tapering strips work. Now, if we look at the results, now, first I have to tell you something about the group of patients that is included in our studies. This is not a group that is totally representative for all the patients in a country. This is a group of self-selected, probably difficult group of patients with respect to withdrawal. Why do I say this? Well, first of all, many of the participants were long-time users. Many of them had earlier tried to stop using an antidepressant or another medication with severe withdrawal symptoms, so much that they could not stop and stayed on the medication for a longer time, hence so many long-term users. And there were also, at least in the beginning in the Netherlands, many patients who had to inform their doctors about the availability of tapering strips instead of the other way around. It were the patients who were searching for solutions, who had discovered that tapering strips were there, who went to their doctor and said, hey doc, I see this and I understand how it works. Would you be so kind to prescribe this to us, to me? And over time, we have seen in the Netherlands that more and more doctors now are the ones who are prescribing the tapering strips to their patients, psychiatrists, GPs, because they have found out that using the tapering strips, their work becomes easier. Finally, there was no additional guidance for the patients who used it other than the information we gave to the patients. But other than that, it was between the doctor and the patients to determine which tapering strip would be prescribed. So we had no control over that. And all these things taken together are very different from what happens in clinical trials. Because in clinical trials, participants are often not representative for the patients who go to a doctor in daily clinical practice. For instance, there's often exclusion of patients who do not have a certain diagnosis. or who also use other medications, or who have suicidal thoughts, etc. Completely different. We have no exclusion at all. We just ask every patient who has used the tapering medication, how did things go for you? That's what we're using for our research. Now, the main results of our studies in 2 lines is that what we found is that 70% of the cohorts we studied was able to taper completely. And there was not much difference between patients who had tried to taper before and patients who had tried to taper for the first time. And because the first tapering strips became available in 2013, there has been enough time passed for us to start asking questions to people who have used the tapering strips to come off medication a number of years ago, in this case about 1 to 5 years. Are you still without the medication you tapered, or have you started using it again? And then about 70% was still off the medication they had tapered using the tapering strips. This leads us to conclude that what we think is that an unknown, what we think significant number of patients appear to be able to come off psychiatric drugs even after years of use and after several previous failed attempts to quit, provided that their doctors will be able to prescribe personalized and easily adaptable tapering schedules based on shared decision-making and proper self-monitoring. And of note, whether this is done using tapering medications or by other means, for instance, liquid medication, that doesn't matter. As long as this is possible, we think that patients can be helped greatly. But since as far as I know, tapering medication is the most versatile and most easy system that's currently available, I think it is important for patients and doctors to know that on prescription, tapering strips and stabilization strips are now available for antidepressants, antipsychotics, benzos, opioid analgesics such as tramadol and oxycodone, antiepileptics, and some other medications too. And since some time, we've also developed switch strips to help people switch from one drug to another in a more safe way. And it was not us, it was not that we were thinking like, let's make tapering strips and these other strips for all these different medication. This came about because once the first tapering strips became available in 2013, from the beginning, we started having questions from patients and from doctors. Do you also have tapering medication for this drug or for this drug and for this drugs? And up to this day, new drugs are being mentioned, which appear to have withdrawal symptoms, which previously were never seen as having them. They were simply not noticed. And for people outside the Netherlands, doctors as well as patients, it's useful to know that this tapering medication is also available for patients outside the Netherlands. And you can find information on the website www.taperingstrip.org, or DE for Germany, or Spain, ES, France, Italy, and also some other countries. Well, to sum up, we have come to some universal rules which we think apply to responsible tapering. The first one is to reduce gradually and hyperbolically, according to the Horowitz-Taylor method, which is more gradual towards the end. Secondly, use shared decision-making, use daily self-monitoring, take the time that is needed. Do not go faster because you think this is easier, because you might regret it as a patient if you go too fast. Better safe than sorry. And in case of complaints which are occurring during a taper, this can be withdrawal symptoms most likely, do not continue tapering further without thinking, because probably if you do that and if you keep reducing the dose, your complaints will start getting worse. So before deciding to go on, discuss this with your doctor to determine whether and how to adjust the tapering schedule, or if your doctor is not readily available for you, decide if necessary for yourself, because it will save you possibly a lot of trouble. Now, the last part of my talk, I will spend some time on discussing self-monitoring. Self-monitoring can be done in many different ways. We devised a very simple form for this purpose, and we gave very simple instructions to patients, basically saying that if you complete this form, you yourself and your doctor can help. This can help you to make your taper go as smoothly as possible. What you should do is complete the form at a set time each day, and preferably at the end of the day. And what you should do is write down the number on the scale between 1 and 7 that you think indicates how much you suffer from withdrawal complaints, where 1 is not at all, 7 is very much. And this is a subjective measure, but because if you fill it in every day, you can see changes, and these changes are important, more important than the precise score you fill in. And if necessary, if you have withdrawal, you can use this form to discuss it with your doctor. And if you do this on the phone, you can take a photograph and send it to your doctor. We think this is really helpful, and I hope to explain with a few examples that it really is. Now, our goals were clear. We wanted to enable patients to help themselves to make their taper go as smoothly and responsibly as possible. The second thing we wanted to do is to help their doctors, because they cannot be expected to monitor patients on a daily basis. They do not have the time. They will not get reimbursed for this if they do this. It's impossible. And finally, we can use these forms to do scientific study of withdrawal as it happens in daily clinical practice, because we need data to be able to say more about it. We urgently need those data, and because people are using the tapering strips, we are getting these data right now. Now, this is one of the first self-monitoring forms that came in. This is from a person who tapered clomipramine from 75 to 50 milligrams. And here you can see the structure of the form. There's a column which indicates the daily dose. You can see how this is lowered during these 28 days. The day of the week where people take the medication. And because we taper, we count down. And this is the score this patient has filled in. And we also offer the possibility to write down which sort of complaints a patient suffers from. And in this case, it's very little, 3 days, gloomy morning thoughts, but otherwise everything goes well. And this is always reported by this patient who is writing down, it is going fine so far. Which means for the patient, I can continue with my next strip and have confidence that things are going well. So as you see, this is as simple as possible. It's easy to fill out. It visualizes how and when symptoms change as the dose changes. And it's informative for patients as well as for practitioners. This is a second example I show. And these are 2 examples, by the way, that we have published in this review. So for a thorough discussion about it, you can read the article. And this is an interesting one. This patient apparently had big problems when tapering diazepam, which is not unusual for people who try to come off drugs like benzos. Had a high score, and at some point it was decided that she or he would stay on 0.3 milligrams, in this case for 28 days. And when you see the score, you see that it starts high and then gradually it goes lower, especially nearing the end. And this is an interesting column because it's written down what kind of complaints she is having. Not classical withdrawal symptoms, but what's important for this patient. Problems with sleeping, and here you see that she or he is also taking an antipsychotic. And this is not uncommon in clinical practice, and often we don't know precisely what is happening there. And here she or he writes down something very interesting. Performing with the choir went well. Well, clearly this is not a withdrawal symptoms, but it is something that apparently is important for the patient. I assume that previously it went less well. So this is an improvement, and this is something that is highly relevant for the patient. And it is also informative for the doctor because this is something they can discuss together. And here she goes back, or he, to a normal dose of Seroquel, gradually less tension and better sleep. And this coincides with a lowering of this score. Less tensions, still a little bit tension. But then at the end, she writes, or he writes down something very important. The sleep has fully recovered during these stabilization strips. I will now continue tapering. And for me, this exemplifies what I would call shared decision-making, which comes naturally, because I guess that the doctor will agree in this case. Well, what you hope, of course, that if you choose a tapering schedule, that you will have no or few withdrawal complaints. So what we would like to see is many forms like this, where patients fill in very low scores and can go on to the next one. So we hope that taper will go as planned until the end. This is an example where tapering is causing withdrawal complaints, and perhaps too much withdrawal complaints. You can see the scores are high, and then at this point, complaints are coming. And the patient here writes down, I will go back to 3.8 milligrams. And this is tapering of paroxetine. And you see very small steps, and still here withdrawal symptoms are occurring. And then we hope that the stabilization will help. This is another example similar to that. You can see the scores are getting higher and higher. And what you also can see is that the patient here goes from 50 milligrams to 25, and immediately the score goes up. So apparently this was a too large step to make. And this is the last example I will show you. And this is an example where I think that you can see that the decision to stabilize for this person comes too late, because this is a first tapering strip. And this is the second one. And the tapering is from 60 to 40 milligrams here and from 40 to 25. But as you can see, the scores that are filled in are quite high already during this month of tapering. And the decision to stop with the tapering comes here. But in my opinion, it would have been much better for this person to start stabilizing earlier and not continue the taper. And I think this exemplifies something that is happening in daily clinical practice, probably still quite often, that patients continue to taper while they are having complaints. And sometimes they hear from their doctor or from people around them, like, you have to keep up, this is just part of the problem, but it will go on. And that's not wise. That's not wise. If you have problems because of withdrawal, it's not wise to continue the taper. And I think that's the knowledge that's so much present on all these websites by all those people who are trying to help patients to taper carefully. The only difference is that we have added a practical tool to make this easier. Okay, well, this is the abstract as we wrote it for our new study. This is under peer review. We have got comments which we are now using, very useful comments to rewrite some things. And I will just point you at two things. This was a sample of 608 patients that we that filled in total something like 1,800 of these self-monitoring forms. And one conclusion I'm willing to draw is that the Horowitz-Taylor method of hyperbolic tapering was really associated with limited withdrawal over time. But Jim, in the next talk, will tell you more about this. And this is almost my last slide, and I like it, because what you see here is a cartoon of what is called reality, where you can see that some persons get more than they need, while others who need support get less than they need. This guy has gotten a hole instead of a box to see this baseball match. This is what we call equality. This is very much the medical model we have now. Everybody has rights. Has the right to get the same support, but having the same support is not always useful, because this person doesn't need extra support. In terms of withdrawal, if this person can taper very fast, he doesn't have to go slower. And this person, if he needs slow withdrawal, he needs a much slower withdrawal, but he doesn't get it. This is what we call equity, where we give people the support they need given the circumstances we have. Here, all three people are helped. But I like specifically the last picture. This was new for me, which is called justice. And this says we should take away certain barriers. If there's no barrier, everybody can see the match in this cartoon. And I think we have a barrier when it comes down to tapering, a barrier of injustice. And that is what currently is happening, that we are making patients pay to be able to taper safely. And personally, I find this a form of great injustice. And I hope that World Tapering Day will help to make an end of this. And this is where my end will talk. Where my story ends. I thank you very much.